Good morning. Today I'll be speaking on masquerades in orbit and oculoplasty, that is, masquerades of eyelid and orbital tumors. So, after all, what is a lie? It's a truth in a masquerade. So, masquerade in ocular pathologies often represent a diagnostic dilemma for clinicians because of their varying and atypical presentation. So, any suspicious lesion in the eyelid or orbit has to be evaluated meticulously. You have to do a protocol-based approach with a temper-based taking history with a precise organized approach for the clinical findings and evaluation and appropriate investigation and a rational intervention for coming to a conclusion and treatment. So some of the red flag signs I'll be discussing along with the differentials. So case 1 was a 68-year-old male who presented with swelling and pain in the and redness in the left eye of 4 months duration. He had a superior bulbar conjunctival mass with feeder vessels with mild proptosis and restriction of abduction. You can see he has got a mild proptosis in the left eye. There were no regional lymph nodes. We clinically diagnosed as conjunctival lymphoma. So MRI also revealed conjunctival lymphoma with suspicious involvement of the lacrimal gland with LDH raised, but incisional biopsy proved to be a moderately differentiated squamous cell carcinoma. So oncologist opinion was taken to rule out systemic metastasis. He was started on mitomycin C, but no response. And UBM was again done by the radiologist for posterior segment of scleral invasion. And UBM was done by the retina consultant, and B scan was again done by the radiologist. And there was no lacrimal gland invasion. So he was managed by excision of the conjunctival mass with AMG and cryo. So coming to the differences between the squamous cell and conjunctival lymphoma, laterality squamous cell carcinoma is unilateral. Lymphoma can be bilateral or unilateral. And clinically, the squamous cell carcinoma has an elevated gel-like mass with feeder vessels with or without surface keratinization. And lymphoma appears like a salmon-colored lesion and usually arises from the B cells. And origin of squamous cell carcinoma, the histopathology, they arise from the squamous cell layer, and keratin pearls or intercellular bridges are very characteristic of a well-differentiated carcinoma, whereas origin of B cell is a B cell, origin of lymphoma is from the B cells. And low-grade lymphomas are extranodal marginal zone lymphoma or follicular zone lymphoma, and diffuse large cell and mantle are high-grade lymphomas. Case 2 was a 68-year-old female who presented with right eye watering and a swelling in the right eye for the past 3 months. She had an inferior pharyngeal mass with scleral thinning, no lymph nodes, and she was clinically diagnosed as OSSN or squamous papilloma. MRI also showed a effacement of the conjunctival plane, which involved the inferior oblique muscle, but incisional biopsy revealed a moderately differentiated squamous cell carcinoma, and this case was managed by lid sparing excentration. So a squamous cell papilloma is caused by a human papilloma virus, and it appears as a sessile pedunculated mass with a fibrovascular core and hyperplastic epithelium, whereas squamous cell carcinoma is most commonly caused by UV radiation, HIV and AIDS patient, and also can be a HPV virus. And these patients, as I said, they have a gelatinous or papillomatous appearance with inflammation and leukoplakia. Case 3 is a 58-year-old female who presented with complete ptosis and protrusion of the left eye, and she had defective vision in the left eye for the past 11 months, no trauma or no fever, and she had a proptosis with inferior dystopia with complete restriction of all extraocular movements, and there was a firm, ill-defined, non-tender mass in the supratemporal orbit which was fixed to the bone and the skin extending to the infratemporal orbit and with mild dilatation of the vessels. And there were no regional lymph nodes. Clinically, it was looking like a lymphoma, but MRI also said lymphoma or histiocytic or non-infective granulomatous disorder, but incisional biopsy came out as a ductal carcinoma of the lacrimal gland. These lacrimal gland carcinomas have very high morbidity and mortality. So, and also we have to first do a systemic workup to rule out a distant metastasis. And this patient, since she had a very large tumor, underwent excentration. So the lymphoma can be well-defined, molding to the globe, whereas lacrimal gland carcinoma can be well-defined or infiltrative. Calcification is very characteristic, can be present 30%, and bony erosion are present. And then IHC also helps in differentiating the lymphoma from the lacrimal gland carcinoma. Case 4 was a 75-year-old man who came with acute onset of redness and discharge in the left eye, and there was a history of trauma. He underwent keratoplasty in the right eye. Vision in the left eye was 5/60, and right eye showed thickened upper lid and lower lid margin with foreshortening of the fornices. So clinically, both eye he was diagnosed as OCP with left eye sterile corneal melt, and he was started on oral and topical antibiotics, and biopsy was already done elsewhere, which showed as conjunctival intraepithelial neoplasia. But second opinion, we got the second opinion slide book, which showed disc keratosis with moderate sin type 2, and he was started on local mitomycin C. 2 cycles were given. So the difference is sin has a gelatinous appearance with and more commonly in the interpalpable region with feeder vessels, and it contains a mixture of spindle and epidermoid cells. And one important thing is it has a clear demarcation between the normal and abnormal epithelium, whereas OCP has a linear staining of the epithelial basement membrane and has foreshortening of the conjunctiva and fornices. And this is a 57-year-old male who came with who came with a recurrent redness and pain, and she considered local ophthalmologist was treated as blepharitis or keratoconjunctivitis, and she had a thickened lid margins, diffuse congestion, and ESR and all the granulomatous workup was negative, and she was diagnosed as chronic conjunctivitis with limbal cell deficiency, and she was not responding to any of the lubricants. So biopsy was done, and she came out as pagetoid variant of sebaceous gland carcinoma, underwent a systemic workup, and finally we did a lid sparing excitation with an orbitoocular prosthesis. So why this case is sebaceous gland carcinoma has a non-specific clinical presentation. Pagetoid the tumor cells can migrate to the epithelial surface and cause skip lesions mimicking a benign lesion like blepharoconjunctivitis, and it's very difficult to diagnose because the average time interval between the presentation and diagnosis ranges from 1 to 3 years. So delayed diagnosis can lead to significant morbidity. The poor prognosis causes an invasion of the vascular lymphatic system, bilateral involvement, pagetoid invasion, tumor diameter more than 10, and delayed diagnosis. So coming to the next case is a 57-year-old male. He presented a small lesion in the upper lid, which was not, it looked like a chalazion, but on eversion, there was a white yellowish proliferative lesion, and this came out as a high-grade sebaceous carcinoma, and he underwent a wide excision with Cutler beard procedure. And okay, so this is the difference between the chalazion and the sebaceous gland carcinoma. The yellowish nodules with effacement of the lid margin and meibomian glands is very characteristic of a meibomian gland carcinoma. This is a patient who came with bilateral ptosis with nodules in the conjunctiva, and she had mild edema and lid edema with conjunctival masses, and she was diagnosed as conjunctival lymphoma, but biopsy showed as amyloidosis. And similarly, another case who came with unilateral ptosis, she also had an amyloidosis, and this can only be diagnosed by doing a HPE, where you can see that by staining with Congo red stain, you can have an apple green birefringence which is seen in the cells. And this is a patient who presented with left eye swelling and with a caruncular mass. It came out elsewhere. It came out as a benign squamous papilloma, but repeat biopsy showed an invasive carcinoma which was invading the nasal cavity and medial orbit, and he was advised total excision but loss of follow-up. And this is a case a small child, a 9-year-old, who presented with a right eye conjunctival mass of 1 month, no history of weight loss or no fever, but and we thought it was a lymphoma or a granuloma, but peripheral smear showed increased neutrophils with thrombocytopenia, and she had lymph nodes in the cervical region, and biopsy came out as myeloid sarcoma, and she was referred to oncologist for further management. And this is a large tumor in the left lower lid, and we thought it was a squamous cell carcinoma, but biopsy showed as desmoplastic tricholemmal carcinoma, which is a hair follicle tumor, and this is after the lid reconstruction. And similarly, this was also a tricholemmal carcinoma, and these tumors, they mimic a basal cell carcinoma. So this was after excision, and the difference is in basal cell carcinoma you have a retraction artifact. That means the basal cells, they show a peripheral palisading, whereas even the hair follicles tumors, they show the same thing, but there is a retraction artifact, or there's a space between the stroma and the tumor cells. Just one more slide. And this is a case, 38-year-old lady who came with a right eye lower orbital mass. ESR was raised, and we thought it is an inflammation or a vaginous, but biopsy showed as eosinophilic angiocentric fibrosis, and the treatment for this is a surgical debulking and oral prednisolone. And this was a last case, which she's a 23-year-old child who came with sudden protrusion of the left eye for 3 weeks, and she was already diagnosed as CMV optic neuritis in our hospital. And but the loss of vision was sudden for 3 weeks, and MRI revealed lymphoma or granulomatous etiology. She was already a case of IG she was a case of post-renal transplant. So biopsy came out as lymphoproliferative disorder. So we have to always keep in mind that it's not just an ordinary inflammation. These immunocompromised patients can also have a post-renal transplant lymphoproliferative disorder. So last case is a 40-year-old female with left eye upper lid swelling. She underwent complete excision of the mass. We thought it's a sebaceous cyst, but finally it turned out to be dirofilarosis. So this is not a masquerade, and this is just a child, and we were diagnosed as conjunctival melanocytic nevus, and biopsy came out as a compound melanocytic nevus. So these cases have to be actually followed up very frequently, because they can always become malignant, these masses. So it's not a masquerade, but we just presented to show the importance of this follow-up. Thank you.